All right, here we go with Lesson 3. We're still in the fundamentals unit of the EMT course. Lesson 3 is on ventilation and airway control. Again, a very important lesson early on in the course. There's many of these lessons that are foundational. And as with building a house, if the foundation's not secure, then you're going to have troubles later. So do spend some time on this. And in the Lesson 2, we talked about circulation. Here we're going to talk about ventilation. There's also oxygenation to be talked about. That's CVO. That's the three big things that we look at. So let's delve into ventilation. This one's going to take you a couple hours online, independent prep. Maybe not totally 2 hours, but we wanted to set it at that anyway. And then an hour in face-to-face in lab. And this is another of the labs that we will repeat over and over because this is absolutely fundamental. And then also, if you're very outcomes-oriented, if you're looking at the National Registry Psychomotor Skills exam, there's stuff in this lesson that is absolutely critical on the National Registry exam. And there's a couple of stations that are in the skills exam that are absolutely aimed right at this stuff. So here we go. Content of this lesson, we're going to talk about airway and breathing from an A&P standpoint, as well as how to control the airway, and then how to assess and manage ventilation. So it's airway and breathing. It's one long word, airway and breathing. And they go together. You can't have adequate breathing with a bad airway, and so we have to work on that. Again, the context here is CVO. We talked about circulation in a previous lesson. We're going to talk about oxygenation in a future lesson. This one's about ventilation. Ventilation's all about getting good air in and bad air out. Airway control is the key, critical first part of that, and then ventilation follows after that. Upper airway anatomy that gives you trouble. The tongue. The tongue is large. The tongue is heavy. It's a very large, heavy muscle that can easily obstruct the airway. The number one most frequent cause of airway obstruction is the tongue. You should know that because someone will ask you that on test questions for the rest of your life. The tongue is the number one airway obstruction. People who are breathing and making lots of noise do not have open airways. Snoring is not an open airway. It's the tongue obstructing the airway. A patient with a lot of fluid, blood, vomit, whatever else in his airway does not have an open airway. Noisy airways are not open airways. Now, the next line seems to contradict the previous line. But think about it carefully. Totally obstructed airways are silent. If there's no air moving, there's no noise that can be made. So ventilation is dependent on an open airway, and noisy airways are not good, and neither are completely silent airways. There's several ways to manage the airway. We like to start with manual maneuvers first. We like to try to position our patient in an advantageous way. If you can position a patient on their back, then gravity is going to be pulling the large, heavy tongue down to the back of their throat, so to speak, their pharynx. So maybe supine, laying flat on their back, is not the best position for them. It might be the most convenient position for us. We might be really accustomed to seeing all of our patients flat on their back, but that may be creating an airway problem that you wouldn't have if you would turn them on their side. So there's great pictures in your book, and we'll show you in lab the positioning to promote an open airway by simply moving the patient from supine to on their side, called lateral recumbent. Now, the name of that position is either the coma position, the drainage position, or the recovery position. It's the same position. It's just got three different names. And different people in different areas of the country will call it by a different name. But when we say position your patient on their side, we're looking for this particular position where their knees are flexed a little bit, their arm is up holding their head, supporting their head somewhat, and gravity is pulling their jaw forward and allowing drainage to happen. We'll also learn how to put our hands on and do a jaw thrust. A jaw thrust is the primary manual maneuver that we use if positioning is not going to work or we have to have them supine. then we're going to need to use a jaw thrust to displace their jaw, their mandible, displace it anteriorly toward the front of the patient. And we'll show you this in lab. You can see it in pictures and videos referenced in the resource document. The jaw thrust is our main manual maneuver. It helps get the most common airway obstruction, the tongue, to no longer be a problem in cases where we are forced to use a supine position. So if we're going to ventilate a patient, we're going to need them supine. If we're going to do chest compressions on a cardiac arrest patient, we're going to need them supine. So it's not the best for their airway, but we don't have a choice. We have to use it. The jaw thrust is how we overcome that problem and get an open airway, maintain a patent airway, while we're also doing necessary treatments. The head tilt chin lift, for those of you that have had CPR before, head tilt chin lift was emphasized when you're by yourself, but when you have help, and we almost always have help, we're hardly ever alone, and if we are, not for very long, head tilt chin lift is a real pain. It kind of gets in the way. The jaw thrust is clearly superior. The other thing that they'll ask you on test questions is, what do you do when a patient has a potential spinal injury? You think their neck may be broken. Well, the jaw thrust allows you to open the airway without really hyperextending the neck and making an injury, if it is there, worse, whereas the head tilt chin lift clearly calls for a bunch of neck movement. So good pictures to look at on that, and we'll show you and have you practice in lab, so be sure that you are prepped for that. Other airway tools that we'll talk about: an oral pharyngeal airway, an oral airway, an OPA, a nasopharyngeal airway, a nasal airway or a nasal trumpet, an NPA. We'll talk about how to use suction, both the manual suction that we have and mechanical battery-powered suction that's available to some EMS responders. Then we'll talk about some advanced airways, most particularly for us, the supraglottic airway, the SGA. This is an airway that is placed above and outside of the larynx, the opening to the trachea. And this can be done without directly visualizing the larynx. So it can be done quickly, and it can be done with minimal training. And once you're able to do it, the training kind of sticks with you. And so the SGA, and in our case, a King LTSD is what we're using now. An SGA is part of this as well. So we get into some pretty advanced stuff right off the bat here with airway control. An oral pharyngeal airway, an OPA, an oral airway, is hard plastic and meant to be positioned in the posterior pharynx, the back of their throat. And so if a patient has a gag reflex, that airway is going to tickle that gag reflex, which may stimulate vomiting, retching, and just cause problems for you. So the OPA would not be useful in a patient who has a gag reflex. Patients who are very unconscious may not have gag reflexes, or they may. And we'll teach you how to assess for that as best we can by providing a painful stimulus to the person. Basically, you take the hard plastic OPA, you squeeze their nail bed pretty hard, and if they don't react to that, then it's reasonable for you to insert the OPA because they probably don't have a gag reflex. There's not a lot of black and white in medicine. It's many, many shades of gray, and so this is one of those gray areas. You can have a person who doesn't respond to your painful stimulus who still has a gag reflex. But in this case, it's reasonable to try it, and the OPA is a very effective tool to add to your jaw thrust to help you open an airway. The OPA itself does not keep the airway open. It's an adjunct to add to jaw thrust. Size matters on OPAs. We'll show you how to size. The wrong size will keep coming out of the mouth. If you size it too small, size it way too large, I suppose. And so sizing matters, and we'll show you how to do that. And then how you insert it is also a specific way so that you don't end up pushing the tongue back and actually causing a bigger problem than you already had. So we'll usually insert this OPA at 90 to 100 degrees away from its final resting spot. And there's decent stuff in your book on this, and we'll show you in lab. Nasal airways, the NPA, works great with a gag reflex. We won't do this in class, but we could have everybody place an NPA and sit in class, and you'd all be able to talk. It wouldn't be the most fun. It's kind of irritating to your nose, but you can use an NPA with a gag reflex. So in the case where you need something to help you with airway control, in addition to, as an adjunct to your jaw thrust, and the patient has a gag reflex because you squeezed their nail bed with the OPA and they pulled away, then you can use an NPA. NPAs are great. You can put one in each nostril. Matter of fact, you can use an NPA and an OPA, or two NPAs and an OPA. You can use lots of airways. There's no rules. You can use lots of airway adjuncts. Sizing is pretty straightforward. We'll show you that in the lab. You can read about it in the book. So is insertion. So, then there's the final thing about a route for medications. One of the most popular, whether it's right or wrong, one of the most popular meds to give these days is Narcan. A patient who has overdosed on an opiate or opioid like heroin or oxy or something like that may not be breathing very well, may need us to ventilate them. We need to control their airway before we do that. And so we'll put an NPA in one nostril and then leave that other nostril open for intranasal administration of Narcan. So not a real big fan of Narcan. It's got its use at certain times. We're probably way over the top with it in a lot of places. But right off the bat, talking about airway control, we wanted to mention, hey, if you're going to give meds up the nose, you can't have an NPA in that nostril. So an oral airway and an NPA is great. Maybe hold off in some cases on using two NPAs. Just saying. There can also be airway obstructions, maybe from swelling, maybe from an allergic reaction that's really out of control, maybe from inhaling superheated gases and they have swelling in their upper airway. There are other causes we'll get into later in the course about upper airway swelling. Maybe they've got some vomit or some blood, or they've choked on a piece of food, or there's some non-chewed food, if that's a word. Maybe there can be food or vomit or blood in their airway, and they could be choking on that, because anything that is larger in diameter than their pinky finger can obstruct and cause them to be choking. So we'll talk about airway obstructions as well. We've got really good manual suctions, the VVAC suction. You use your hand and you squeeze the thing, and it provides excellent suction. If you work on an ambulance service or some fire departments, first response agencies will have battery-powered mechanical suction. They're only marginally better, probably, than that manual suction. Plus, they're battery-powered. So if the battery's not working, then the suction is worthless. And so almost everybody will have manual suction, at least as a backup. And on our fire department, we carry them as our primary suction device. They're awesome. It's good to practice that in lab. Then there's also advanced airways to talk about. Now, paramedics can place an endotracheal tube, the ET tube, the ETT. Paramedics can do a cricothyrotomy, where they surgically make an airway through the Adam's apple. And then there's the supraglottic airways, the SGAs. Some services and some departments will carry something called a combi tube. Some will have something called an iGel or an LMA. Our fire department carries a King LTSD, and so the King airway is our supraglottic airway, and these are airways that are above the glottis. Supra meaning above, supra meaning above, glottis meaning the vocal cords and the opening to the lungs. So these are placed above that, not through that like an ET tube, or past that like a cricothyrotomy. But the SGAs are a skill that EMTs possess. Now, it's not tested on National Registry, but it's a key component of high-quality CPR. So not to digress too much here, but I need about 30 seconds to preach the gospel on CPR. High-quality CPR is the only thing that really has been shown to matter in cardiac arrest management. Defibrillation's nice, meds are nice, but really high-quality CPR is the key. High-quality CPR is based on two things. One is doing really good chest compressions, and the second is not interrupting those chest compressions. In order to ventilate a person without an advanced airway in place, we have to pause the compressions, interrupt the compressions briefly to allow for breaths to be given, for ventilations to be given. But if we can use an advanced airway, like an SGA, that can be placed quickly by EMT level folks, then we can avoid that interruption for ventilation, and now we can have high quality compressions that aren't interrupted, and now we can have high quality CPR, and that's what matters. So that may have been longer than 30 seconds, but that's the basis. So why, very early in your EMT course, are we talking about a very high-end thing like an advanced airway? Because it matters for cardiac arrest. It really matters. And so we want to work with you on SGAs. The one that we use is the King LTSD. There's some good stuff in your resource document. Here's how you deal with it. You find it in your bag. You size it, which is pretty quick. You check it real quick, which means you inflate some air into the cuff. It has a cuff on it, a balloon on it, that inflates and needs to hold a seal. So you got to check that seal. Sometimes they're bad right out of the bag. So find it, size it, check it, place it in the patient, inflate the cuff so that it seals, and then ventilate your patient and adjust it. So right now, as prep for this next lab, you could be learning those 6 steps. And you learn 6 steps by making lists and flashcards and repetition, repetition, repetition. Find it, size it, check it, place it, inflate it, ventilate, and adjust it. So start working on that. That'll be very helpful as we move forward. There's 3 things that could happen when you place that king. 3 things we need to figure out. You can start learning this too. This would be great for flashcards. It could be that you place it and the patient is easy to ventilate and you have a good chest rise. It's a happy day. All good. It could be that it's easy to ventilate the patient, but you don't have good chest rise because the cuff seal is leaking. So you put some more air in the cuff. Make the balloon seal a little bit better. This will make a lot more sense when you're in lab and you can see this. It could also be that it's hard to ventilate and you don't have any chest rise. That means you're just too far down because you placed this without being able to see where it was going, and it ends up that maybe it's the wrong size. So you pull it back a little bit until it's now easy to ventilate and you have good chest rise. Everything's good. So that's the 3 things about the king. And again, start learning this. Start working on flashcards with this. Start saying this to yourself and quizzing yourself at various times. When you're at lunch and you get done eating, stop, grab an extra napkin, and write these 3 things out. Write out the signs of shock. Write out the treatments for shock. Write out the types of shock. Write out King Airway stuff. So this is about ventilation, and we've talked about airway control to this point. Now we're going to talk about ventilation. Ventilation assessment, that's what AX means. AX is assessment, TX is treatment. So ventilation assessment, 3 things. Again, more flashcard stuff. We're going to check for rate, effort, and depth. RED. Rate, effort, and depth. Their breathing rate could be too slow or too fast. Now that's pretty embarrassing because I just noticed a typo on this, and I'm not going to stop to fix the typo, but I know that there's 2 O's in 2. So it could be too slow or too fast. If they're breathing 4 times a minute, that's not fast enough to have normal ventilation. If they're breathing 40 times a minute, that's way too fast. So we think the normal is somewhere between 8 and 28. If they're breathing less than 8 times a minute, like 6, Think about that. That's once every 10 seconds. Try to breathe 6 times a minute right now. Take a breath, not a big deep one, just a normal breath, and count to 10. It takes forever to get to 10. So that's way too slow. Less than 8, you ought to ventilate them. More than 28, think about that. That's 30 times a minute or more often. That means you're taking a breath every 2 seconds. Well, clearly that's breathing too fast. So less than 8, more than 28, you ought to ventilate. What about effort? Well, here's a big deal. Be sure you understand this part. When you inhale, that takes work. That's normal. When you exhale, you're simply relaxing. That shouldn't take any work. If you're working to exhale, that's not normal. So we should not have a really long expiration. We should have a normal inspiration for a count or 2, and we should exhale for 2 or 3 counts. But we shouldn't be working to push air out, have a really long expiratory phase, a long exhalation. And then depth matters too, right? If you're breathing 10 times a minute, the rate's okay, but if you're not breathing very deeply, you're not moving an amount of air in and out that matters. Depth is kind of subjective, but normal breathing is not completely as deep as you can. Abnormal breathing is way too shallow. And then we're talking about positive pressure here. So think about this. Take a breath. You just inhaled by creating a small negative pressure in your chest. Negative pressure breathing is normal. It's not normal for us to blow air into you. You suck air in. So naturally, the way we were built is that by inhaling and creating a little negative pressure, we cause a little bit of a vacuum inside our chest, and that helps blood flow back to our heart. Negative pressure breathing, normal breathing, gives you normal dynamics, normal pressures inside the chest. Normal preload. Preload is the amount of blood coming back to the heart. When I do positive pressure on you, now I'm putting positive pressure inside your chest, which is kind of resisting some blood flow coming back. So ventilation can impact circulation. Positive pressure breathing is not normal, and it reduces preload, which can reduce your blood pressure. So we don't want to do positive pressure unless we have to. We don't want to do it any more often than we have to. We don't want to do it any deeper than we have to. We want to do positive pressure ventilation the right way and only when we need to do it. Another thing that can happen when you're blowing air into somebody's face, positive pressure ventilation, as air goes into their airway, you hope it goes into their lungs, but it's a lot easier for it to go on and down their esophagus into their stomach. So when you give somebody a breath, some will go in their lungs, some will go in their stomach. Good ventilation gets more of it in their lungs than in their stomach, but you still, with any positive pressure ventilation, without an advanced airway in place, you're going to have air in the stomach. Air in the stomach causes gastric distension. Air is in the stomach. Gastric distension leads to vomiting. Vomiting leads to airway problems. So positive pressure ventilation is not without a side effect. And the side effect, a side effect is defined as something that happens and we're not shocked that it happened, but we sure didn't want it. So a side effect of positive pressure ventilation is gastric distension. When your patient's breathing 4 times a minute, you want to breathe for him. You don't want to fill up his belly with air, but it's a side effect of even properly performed positive pressure ventilation. The mask seal is extremely important. Unless you have an advanced airway in place like a supraglottic, like the King, then you've got to get a good mask seal in order to get air into the patient, whether you're blowing that out of your lungs or you're blowing it out of a bag valve mask. And we'll play with this in lab, and we want you having your 2 thumbs pointing down toward the patient's feet, 2 thumbs down. And you want to combine that with a jaw thrust. And once you get this down, it is so easy to use on a real patient, and it's very effective. So 2 thumbs down, good bag good bag valve mask ventilation are key things that we want to learn and practice over and over and over in our lab. What tools will you use? Well, you've got the pocket mask, that's a one-person tool. Got the bag valve mask, that's a two-person tool. So anytime you see something in bold like that, and then you hear us say, this is really important, this is a key concept, then you can bet that that's something you should know when you walk into lab. In order to be ready to participate in the lab, you have to have prepped. If, as part of the knowledge check to see if you're ready to participate in that lab and not slow down the other folks with you in the group, we give you a knowledge check, and on that knowledge check we say, bag valve mask, one or two-person tool. You got to know it's a two-person tool. It's really important that you know that. So that's some of the things we'll play with in lab. And then your technique on bagging, technique on bag mask ventilation. We want to use just enough volume to get chest rise, not the most you can get, just a normal chest rise, and only use enough pressure to get that chest rise, and don't do it too often. And that too often is once every 6 seconds for an adult. So you can practice that. And after you have been in lab, we'll send you home with homework. We want you to walk around squeezing the bag. You have a pretend bag in your hand and you're miming that you're squeezing that bag. We want you to do that no more often than every 6 seconds so that you have a 10 ventilations per minute rate. Just enough volume, just enough pressure, only no more often than every 6 seconds. Bag mask ventilation technique is key. We'll work on that in lab as well. So this presentation has been all about ventilation. And the first part was airway control, because we really can't deal with ventilation if we don't have a patent airway. So how do we position the patient? Use a jaw thrust, use oral or nasal airways, OPAs or NPAs. When is it appropriate to move to an advanced airway, which at the EMT level in Missouri, you can do a supraglottic. And our supraglottic of choice is the King. And when the King, you find it, check it, right? Do that. So this is the stuff to prep for. So you can walk into this lab, pass the knowledge to the readiness check, be ready to go, and have a real good lab experience where we really can help you start to learn this stuff and become second nature. So that is the conclusion of our lesson here, and we're going to be wanting you to do that assignment, look at that resource document, and fill out those questions and prep yourself. Do the work, do the prep work so that the lab can be very effective.